So, please. Thank you. I don't know where to stand. Will it be better there or there?
Wherever you like.
Okay, I'll get outside. Maybe here might be the best one.
Yeah, that's fine.
First of all, thank you very much. I'd like to express a special thanks to Anna, who is not here. She was, I think. The second thing is that obviously English is not my first language, so you might hear some French words inside of my presentation, but I will be supported by And the second point is essentially to, or the third point is to, for an organization that is supposed to be really modern and evidence-based, the photo that you have from me is an old one, so I'm not accurate. We're not accurate in that, so I expect that you will still recognize me. From the beginning of the day, I'm thinking about this presentation because I found very interesting all the presentations so far, and they really apply in the mental health domain, which my presentation will not. It will essentially try to explain how we manage all those questions about expert services or general services or even social services in our own context in Quebec, which is a province of Canada, and I will just explain in a few minutes. So the main objective of this presentation is to describe this institute, which is called the National Institute for Clinical Excellence in Health and Social Services, and it was developed very recently, about 8 years ago, and we were mentored by a team of INESSS, which still is an important partner for us. But the point is that I will try to, even though, I mean, I think that the best interest for this afternoon concerning the Canada or Quebec experience will be the presentation from Mrs. Valérie. So I will kind of shorten a little bit my presentation, but it might be relevant for you if you ever wish to answer to your phone or to, so that's okay. She just received a message that I'm really out of the scope of the interest of the group, so I do understand a little bit. So essentially, it is if you ever wish to move in your own context with an organization that is really embedded in the healthcare and social services system, but differently from others, and that looks like some other HCA businesses, like the one in UK with NICE, or in some other jurisdictions. And so thank you. I just thank you because of the kindness of receiving me here. I had the privilege to be in Columbia last year doing a presentation, a speech for what's going on in Quebec, and she attended to it, and since then I think that she felt that it might be useful for me to participate in that workshop, so thank you very much. So essentially, the objective, I mean, first of all, I'd like just to insist on a few points. The first one is that I will talk about this institute, which is part of Canada. In Canada, we do not have one system. There are different systems for each provinces. There are some similarities, I'll talk about that. But essentially, it differs from one province to the other. Quebec represents a quarter of Canada. The second point is that we do not have private health systems in Canada, only public systems. We have private services sometimes, but essentially public systems. So this differs us from a lot of other countries of the OECD, of course. The third point is that we are a population of about 8.5 million people, which is a little bit lower than here in the Czech Republic. But still, we have some common ground concerning our health status, and I've noticed that we share almost the same mortality, morbidity. It's almost the same, except that we drink a little bit less beer than you guys, but a little bit more wine that are not only produced in Quebec, but recently, since a few years, produced some of them. So the objective is essentially to present in the perspective of Back to the Future what's happening or what's happening the invention of INESSS, which is this nice institute. Okay. And the plan is to first look at a Canadian outlook, Quebec, then INESSS background and French perspective and conclusions. So for a Canadian background, you all know Canada, where it is. If you don't know, it's just over, I mean, on the top, on the of the States, which is seen differently from them. So anyway, the point is that Quebec, as I told you, is one of the 10 provinces, and we have 3 territories, and Quebec in itself is completely responsible for any health and social matters. The feds do control a part of the money, but they do not control the organization of health services, as you will notice. The other thing is that Canada, if we look at the investment per capita compared to the life expectancy, which is one criteria, is just in the middle of the most of the pool, so we're not better than others. We're exactly on the curve, much better than the United States. In fact, for all the studies that we're doing in Canada or Quebec, we always want the United States to be part of it because we don't want to be the last of the group. So it's very important for us always to be compared to the States. Anyway, those figures are not necessarily accurate, but the global picture is. So Canada is still investing about 11% of this is GDP compared to the States, which now are higher than 70%. And I think that here in the Republic Czech is still under 8%, what I've checked recently, which is a little bit less than we do. And for our expenses, most of them are coming from the public systems, even though there are some contribution from the citizens themselves, but mostly for medication or some of the rehab or social services that you will notice. And recently, so a couple of weeks ago, we observed that in Canada there's about $270 billion spent this year for the health expenditure. And since, let's say, about 45 years, it's always growing up and growing essentially much more faster than the economic capacity. So there's a question of sustainability behind those figures. And as I have said, in Canada, we spend about, I mean, there are no private system, but since then, there are still about 30% of the expenses that are paid directly by the public, mostly with the complementary insurance program, but essentially not for medical services, for other things, and mainly medication, compared to the rest of the OCDEs, which are a little bit more generous than we are for public system, even though, and I'm still insisting on that, there are no private hospitals, there are no private systems, there might have some very rare physicians that are working privately, but essentially for medical services, as for psychiatric services, they are all offered by public services. And in the last 45 years, we observed that essentially this picture showed you that the investment, collective investment for the expenses in hospital is going down, and this is a progression that we still observe and that we should observe in the next future also. So it's now less than 30%, which was 50 years ago around 50%. person. So there are changes coming on, and of course medication are more expensive. So this is not important. The important, just as a signal here, since 50 years or more or less, even 60 years, the federal government, even though they are not directly involved in the offering of these, controlling the healthcare services, do support financially the implementation of public services. So it happened 60 years ago for public insurance for hospital services or even medical in the community. So in fact, in Canada, everywhere, the systems are publicly administrated, of course, comprehensive, so everything that is medically required has to be offered. Everything medically required. And in medically, you find medical, which is medicines with doctors, things offered by doctors, except for some, I would say, aesthetical surgery, of course. But for the rest, it's all covered. Universality, everyone is covered. If you wish to transfer one from a province to the other, they are still covered. And there are no financial contribution. It is impossible to have fees, and it's impossible to have a counterpart like what has been said this morning by the colleague of Netherlands for the 200, or this afternoon, I'm sorry, for the 200 euros, that would be completely impossible in Quebec as in the rest of Canada. So this is quite important. Now, in Quebec, a province of about 8.5 million, mostly French speakers, and with a good life expectancy and an aging of the population. In fact, we're on the most aging population of the world so far with the Japanese. So we're moving from 12.5 to 25% of the people over 65 in around 30 years compared to 90 years for France or even some figures for UK and probably UK. And for the life expectancy is still going up. Not necessarily because of this health system, but because of other action of determinants, of course, but still moving up. And since 50 years, every day, since 50 years, we've moved every day 5 hours more of life expectancy on everyday basis since 50 years. So it might impress you, but this is the fact. And if you look at your own figures here in the Republic Czech, it's almost the same. So it's really impressive, but still good. As I said, Quebec is irresponsible for all the thing that covers the health and social services. And in fact, this is the only province where the mental, social, and health services are linked together under one ministry. So there are no counterpart from another ministry. It is all embedded in the same ministry. This is really important because it has eased our movement for trajectory of care design with mental health issues, social services issue, and of course health issue, which is something very different in Quebec from the rest of the other provinces in Canada as their territory. And concerning, is it okay so far? Yeah. Concerning, we began that.
Very good.
We began later.
Yeah,
We began later.
Yeah.
Okay. Oh, okay.
And I also postponed the reservation for us for after.
Okay, great. But I have my office in the phone. So, INESSS background, first of all, just to, okay. So we know internationally that there are three things happening right now. Rapidly expanding knowledge and technology. INESSS has the responsibility not only for the mental services, of course, but for technology. So essentially, INESSS is doing three things. First, it evaluates any type of technologies should it be a high-level technology in cardiology or medication before it would be added in the healthcare system coverage. This is his first mandate. The second is to promote excellence of care. So any type of trajectory that we are asked to look at, we should study it and recommend some adjustment, should it be in mental health, social services, or health design. And the third, which is upcoming, is to look at variation in the clinical practice and to pinpoint the places where there are spaces for adjustment compared to norms or to differentiation between one test to another in our product. So essentially, with that in mind, we know that they are rapidly expanding knowledge and technology capacity to do a lot of things, increasing healthcare needs, which is the case in our province, mostly related to demographic transition, and some argue that it's also linked to environmental degradation, which is completely proven right now for us. And of course, increasing pressure on governments to control public expenditure, including rising health costs. So, the health systems that we work with, and essentially ours too, of course, the policymakers and managers need to tackle three issues. First, how to manage quality. So how to ensure that all patients and community for any type of services receive the best care and services. The second is how to promote efficiency, that we can ensure value for money, and finally, how to make evidence-informed choices among competing priorities in context of limited resources. So INESSS was created 8 years ago, and before that there was an agency for health technology evaluation that was more linked to a university, an hospital university, and there was a council for medication, but those have been brought together 8 years ago, and since then we're moving up with now a bunch of around 250 people. So essentially, INESSS is an arm's length body, so it's really important. We are not influenced by the politicians. We have been designed by the politician, but we are not influenced right now by them. So we have our own law, which details our mission, principle, mandates, and functioning. And we have to ensure the quality and long-term financing issues of the healthcare system, and through an arm's length body to ensure scientific credibility and, of course, political legitimacy. So two missions, I told you about that: clinical excellence, efficient use of resources. And the social sector is also included. I insist on that because it's not often that HE agency like ours will have to deal with those, but it's really important for us, and it has been really important 5 years ago when we had a lot of resources coming from the institutions to really structure more solidly this capacity. So, in fact, just to remind you or help you to see that before our existence, about 12 years ago, there has been a committee, a national committee on this question. I was part of it. I used to be kind of said that this morning, STP. I was responsible for a region of 1.4, 1.5 million people, essentially with all the mandates that you described this morning in Quebec. We were organized that way at that time. And I was invited to look at this project with other members of the community or scientific community and politicians. And we concluded that there was a need for a law and structuring an institution to determine projects connected to health and social services, so together, not only to recommend drugs and technology, but to guide their optimal use as the rest, to develop recommendations with stakeholders, which was really important in our perspective, to foster implementation of recommendations. So that differs us from other HC bodies. We we are accompanying, the implementation of our recommendation, and to have access to all the clinical data that are needed. And of course, there was some tension with the mandate that we should have, looking at the basket of public services, should that be in or that be out. So we didn't intend to keep those recommendations. As for the global assessment of the performance, which is now the responsibility of another body. Guiding principles, excellence, independence, which is very important, openness, scientific rigor, which does not surprise you, transparency, our processes are all on the website, integrity and equity, which is really important in our perspective of recommendation, because it's the main interest is to be equitable between some clientele and to others, and about the perceived cost of all of the things we're doing for all the population. So our mandate, as you have noticed, clinical advantage, cost of technology, recommendation and developing clinical guidelines in all the type of intervention, including mental health, determining service performance evaluation criteria, specifically for the subject that we are asked to look at, and fostering implementation of recommendation and practice guidelines, making recommendation for specific medication that was in our law, defining and publishing our method, and of course carrying out any other mandate that our minister wished us to do. So as a mainframe, we're now just changing today. In fact, it's beginning today, the structure of our organization. So essentially, it's a bunch of 250 scientists. In the last 5 years, I think we have hired only 2 people that have a master's degree. All of the others have PhD or postdoc. So it's a very well-trained personnel, much better than I. I'm a physician specialist in a lot of things, but believe me, I do not always understand what they explain to me. I'm sorry. I should not say that because I'm registered and I have one of my bosses here. But anyway, they're very good. So we just we adjust our structure to be more efficient scientifically and to being able to sustain our methodology, which is really relevant on an ethical perspective and for other matters, and especially for the economical perspective. Because as you have noticed so far, our mandates needs for us to be a very competent and very well structured for economical analysis. But this is not the only part that we need to be well structured, because we have to cope with all the implementation issues and make choices that are not always uniquely based on an economical perspective, of course, but for other matters. So, in fact, we have a board, and Mrs. Vassiliadis who's a professor at the University of Sherbrooke, is one of the 11 members of our board. So that's why I have to be very polite. And and it determines the structure of our organization after our suggestions and the Institute's strategic direction. We have an advisory panel composed by different stakeholders that will ease us in the presentation of the priorities to the minister, and that will also examine or foster concerned approaches for implementation of our recommendations. Essentially, we offer 4 types of products: state of practice, state of knowledge, clinical guidelines, and recommendations, which differs in their methodology, but the most important are clinical guidelines and recommendations, of course. So we have a scientific council that is for all the organization, with people coming from out of our organization, of course, and that is there to advise on our methodological inquiries and support our quality assurance process. And we have a lot of scientific committees that are made up, that are made from exclusively people from out of INESSS. So scientific clinicians, ethicians, always. We have to manager, economists, and representative of the population. So those committees will deliberate our recommendations, and they are supported by, of course, expert panel, but at the end of it, they are the ones that will recommend the things that I will send to the minister. And so far, the percentage of success with the minister is 100% for any technology, biological test, and medication, everything, and about 90% for all the rest. So it's fairly good for us. Still an arm's length, and we have, of course, a lot of integration with the minister. We are arm's length. We are not part of the Ministry of Health and Social Services. My boss, I'm designated by the Conseil des Ministres, Council of Ministers of the Government, and my official boss is the Minister of Health and Social Services, but I have a board, which I refer to for all the things that you've seen so far. So we have coordinated committee with the minister so we can work with them and specify the priorities that they wish us to work on. And we do not have the rights to develop our own priorities. It always has to be accepted by the minister herself, which is okay. So since about 5 years, now 4 years, we have access to all the information system of Quebec. So, and we're still struggling for some of them because it's complicated, but it is essential for us to have access to all the information. We are the only one that do have access. So there's a lot of research centers that are looking for them, and we cannot share those information, but we do have access for our specific mandates, including mental health mandates, and I will get through those very quickly. So essentially, in a nutshell, promote clinical excellence and efficient use of resources, being the reference to informed decision and practices, and you know the values so far. And so we have the opportunity to look at all the technologies, recommendation, everything, but also to evaluate and health and mental health, the word mental is missing, I'm sorry, and social services coverage, promote excellence of care, and analyze various practice. So what we do is to produce guidelines and web difference and documentation, a lot of them, which are, of course, evaluated in their impact, because it's really important for us to see, does it worth it? I mean, do we do something that will be useful, which it is so far. So various types of tools, and I will move ahead. Essentially, for everything we do, we always trying to reintegrate scientific data, contextualize data, and experiential data through the mobilization of patients and citizens, or patient or caregivers. This is mandatory in our processes. If we do not do that, it's over. I mean, we have to always cope with those important aspects. Marie-Hélène will develop about our last scientific approach across the organization, so I will just let you know that it has been renewed in the last few months. And on the mental and social services, Hélène Maria will talk about. For the health technology, you know what it is, and I don't think it's really relevant here, so I will cross over it, and it's very complicated now with all the new technology and the design of it and the complicity that we have to have with other partners inside our jurisdiction, companies, labs, and physicians, of course, but also with ethicians and analytical evaluation and participation of the population, of course. And we use the definition of Michael Porter of the value added that we always looked at, so which is the health outcomes over the cost. So it's really important, and of course this is part of your expertise of most of you guys, so it's not a great surprise. So we look at the efficacy, the effectiveness, and efficiencies. Does it work in clinical trials, in the clinical practice, and does it contribute to efficient use of resources? And since a couple of years, we're now completely submerged by the real world evidence capacity that we're now almost having for our presentations, our recommendations, but to the follow-up of them, which is really important. So I will move on for that. And there's a new way for health technology. But the most important is that we analyze now the clinical variation. Those are not issues of mental health, but we're able to follow the use of technology or trajectory of care for all of our institution, establishment, or group, or family practitioner groups. So we're able, with all the data that we have access, to look at variation in practice. So instead of trying to change all the province of Quebec by saying, yeah, now we have to do that, we can tackle and pinpoint the ones that are not comparable to the rest, and that they are not using our recommendations or the basis recommendation of the modern practice of mental health or other issues. So we can work with that, and we are developing that really recently, but this has a great future. So I will not, I will just let you see that we observe, in fact, that the benzodiazepine, which is really used for mental health problems or situation, are moving down in our province, which is great, and we have made a lot of recommendations on that. But for the people over 65, it's going up. So there's a problem, and we can use our information system to see what's going on over there, who is prescribing, what type of group of physicians are prescribing those, and how we can work with them to change their practices, because we're invited to work in clinical governance, not as clinicians, even though some of them are, some of ours are, but mostly, of course, through clinical guidance. And finally, our perspective is to essentially move from data to practice. So there's challenges over data management, knowledge management, data to knowledge, which is really important in our own context. So the contextualization is really important there. And how to change that knowledge that we can deliver to essentially move with changes in practice, the clinical practice. So those are our three challenges linked to the support of learning systems. So thank you very much, and I will leave this investigate this.